Okay. And that kind of leads me to my next question. Initially, about a month ago, it was pretty much thought that there were some gastro symptoms that were kind of early predictors of some of the more common symptoms, fever, shortness of breath, and whatnot. Um, in that month, in the last month, has that understanding changed or basically been confirmed?
Well, there's been a variety of reports now. I think it's really important. The early report of hospitalized patients with COVID-19 had an astonishing 48% of patients who had digestive symptoms as part of their hospital symptoms and hospitalization. Most of those had concomitant respiratory symptoms, and of the patients who only had digestive symptoms, 6 out of 7 had fever with it. So we learned early on that of the sicker COVID patients, it's rare to just have digestive symptoms. Then reports emerged of the people who weren't hospitalized and how they developed some digestive symptoms, and they can be before the development of these other symptoms, or maybe this is all that somebody will notice and they won't progress to a more respiratory manifestation, although that seems less likely. What we've learned now is that you can detect the viral RNA, the viral machinery and genetic components in stool. But so far, we also have known that you can't culture the virus from the stool. So to be careful, we have been discussing whether fecal transmission is possible. So maybe not just the droplets from the way you speak or when people sneeze or cough, but actually in the liquid stool or on the toilets, that there may be viral particles that are transmitted to other people. That's an interesting consideration, but in order to do that, you have to be able to culture virus from stool. Now, we aren't culturing it either because it's deactivated as it goes through the digestive tract, or because our techniques to look for it that way are not very good right now. It's an important ongoing discussion. And just to be careful, our colleagues in GI are now wearing full protective gear when they do colonoscopies, just like they're doing when they do the upper endoscopies, where we were more concerned about aerosolization of particles. So we don't know the answer yet. We don't know if it's going to be reasonable to be testing stool to look for clearance of the virus. We know that it may last longer. We know that the gut expresses the same receptors as the respiratory tract that are involved in how the virus gets into our body. So it's entirely likely that there's more there to that story. There's also been a couple case reports now, and maybe more will be coming, of people who were otherwise completely well, who develop a type of inflammatory colitis or type of really profound digestive symptom where they get sick just in that manifestation. A woman who developed almost a secretory type of diarrhea, very voluminous diarrhea and renal failure, and unfortunately died from COVID-19. And another report of someone who developed a brand new type of hemorrhagic colitis, bleeding colitis, that looked like ulcerative colitis. So there's still more to be said in this story. It appears that that's a rare manifestation if it's real, as opposed to things that are coincidental to all the other diseases that might be happening.
Okay, thank you. Now, going back to the IBD patients, those who are asked to switch off of the immunosuppressants, do they have any alternatives or options to kind of treat their underlying IBD without weakening their immune system?
Yeah, it's a great question, because patients who've lived with inflammatory bowel disease and who finally achieve remission from effective therapies are people who are also very attuned to the risk of relapse if they go off the treatments. Many patients have become sensitive to that consideration, or are very worried about stopping their therapies. The first thing to know is that if you're in deep remission, and that means that you're feeling well from your IBD and your bowel is healed, your labs are normal, if you stop your therapy for a couple weeks, in general, you're going to stay in remission. It doesn't come back that fast. So to reassure people, most patients who need to hold their therapy while they're getting through a COVID-19 episode will do fine from an IBD point of view. It's important to remember that. And of course, most people who get COVID-19 do well, but we know that there's obviously very serious consequences in many other people. The second thing to know is that if you have active IBD and you're barely getting by with whatever treatment you're on, and then there's a concern about COVID-19 and you have to stop your therapy, it's likely your IBD will come back and will give you more problems. In the interval between stopping your therapy and letting the COVID-19 running its course, there are some things that can be done. Steroids at a lower dose can be used sparingly, and they're probably fine. The recommendations in our guidance about avoiding steroids come from using much higher doses of steroids for people who develop respiratory failure, which was learned from the original SARS and MERS, and even with pediatric RSV, which is a pediatric viral respiratory illness, that high dose steroids can make things worse, but lower dose to control bowel problems might be fine. We also suggest that in certain patients, dietary management of Crohn's disease, if you're working with the right expert, staying on one of your therapies if it's high risk is reasonable, or knowing that that drug's going to stick around in your system for a few weeks because of its half-life, how long it's going through your body before it gets cleared, is also important to know. We now have some evidence that being on anti-TNF therapies like infliximab or adalimumab or golimumab, those treatments actually may reduce the inflammatory reaction in the lung, and there's work that's going on to investigate that. And there's also some ongoing work to think that other treatments that we use for IBD may either have antiviral properties or at least prevent the overactive immune response of the lungs. So this is a moving target for us. We just had a webinar early this morning where we're trying to figure out if some of our treatments may actually be protective. It's too early to say that. I don't want to misrepresent the information, but I do think that people shouldn't stop their therapies without knowing that they need to, and they should definitely be paying attention because we may change some of our thoughts as we learn more about all of this. The last comment I have is that some of the treatments for COVID-19, including the hydroxychloroquine that people have talked about, and including a treatment called anti-IL-6, which is another anti-inflammatory protein treatment, and possibly some of the other treatments that are being investigated, may also help the bowel. So it's not the strongest evidence, but when we treat the COVID-19, we may also and secondarily be helping the inflammatory bowel disease. So people shouldn't worry that they're going to just come off their therapies and get sick right away, or that they're going to come off their therapies while they have COVID-19 and they're definitely going to have a flare of their IBD. That may not happen either because their disease is stable, because the medicine they were on for their IBD is still sticking around, or as we learn more and start doing this, as we start treating COVID-19, we may find that the treatments for COVID-19 are actually perfectly fine for IBD. This is why it's a complicated discussion. It's a good question you ask.